Hi friends, let's quickly discuss NEET PG 2023 Psychiatry Recall. If you look at the analysis of the recently conducted NEET PG 2023, yes, the paper seemed to be quite easy, but when you go in depth, it was a moderately difficult paper. One. Second thing, there were a lot of repeat questions in the sense like there were a lot of repeat topics which previously the national board used to ask very oftenly, right? So coming to psychiatry per se, there were around 5 questions directly from psychiatry and 1 questions plus or minus psychiatry or neurology. So let's start with the discussion. So the first question here is: a medical female student presented with repeated episode characterized by breathlessness, sweating, hyperventilation, and impending heart attack. Multiple episodes in a day, lasting for more than 6 months. All the investigation didn't reveal any obvious abnormality. What is the likely diagnosis? So many people, those who have read the notes, with just an important marker here, that is impending heart attack, they must have marked the right answer as panic disorder, right? So if you look, impending doom is a classical MCQ clincher for panic attack. Right? So here they have clearly given repeated episodes of autonomic arousal signs, breathlessness, sweating, hyperarousal with impending heart attack, right? And investigations revealed no abnormalities. What else you need, right? So yes, we have discussed that in the class. So again, the panic feeling of impending doom, that is very important. So if you see anxiety disorders, there are 3 prototype anxiety disorders. One is panic, one is phobia, one is generalized anxiety disorder. Here in this question, the most of the confusion happened between panic and generalized anxiety disorder, because there was one student saying that it is for the last 6 months. See, please note, even though if it is last 6 months or 1 month, panic is always panic, right? That's what I was clearly telling here. This generalized anxiety disorder always will have a free floating anxiety. So panic disorder, suddenly without no trigger, there will be autonomic arousal signs with impending signs saying that I will die right now. The heart starts pounding and I will feel a sense of impending doom, right? So GAD is a free floating anxiety. So what are the treatment for any panic disorder? It is benzodiazepines and selective serotonin reuptake inhibitors, and non-pharmacologically it is CBT and ERP, right? So that was a pretty direct question, and I think those people who are revised the notes have gotten it right? So coming to the next MCQ 2. So again, in our last initiate also there were 3 questions directly from the alcohol and related topics, and here again 2 questions directly from alcohol. Yes, alcohol is always a very important topic of interest. History of chronic alcoholic presented with symptoms of acute confusion, ataxia and 6th nerve palsy, and there are signs of nystagmus. What is the likely diagnosis? Very easy question, right? Chronic alcohol with all the features suggestive of GOA, right? What is this? Global confusion, ophthalmoplegia and ataxia. I have discussed multiple times. In ophthalmoplegia, 6th nerve more than 3rd nerve, and classically they have asked this. Please look, 6th nerve palsy with nystagmus, acute confusion and ataxia. Signs of again GOA. What is the answer? Here? The answer is Wernicke's encephalopathy. Direct question, right? So in Korsakoff syndrome, there will be classical history of confabulation. Okay, right? And this was another option, D. Clerambault syndrome. D. Clerambault syndrome is, delusion of love, where the lower socioeconomic status female thinks that he or she thinks that she is in love with a higher socioeconomic status guy, right? That is Declarenbold syndrome, right? So no confusion, right? It was again a pretty direct question. Again, second question from alcohol: history of chronic alcohol use, nutritional deficiency. Yes, repeated times we have told. See, when a patient a chronic alcohol comes to casualty, the first treatment that always you given is thiamine infusion. So again, that I am telling, the last question that I have discussed. So the classical pathology behind this Wernicke's and Korsakoff is deficiency in thiamine. Right? Deficiency in thiamine. So again, sometimes they might ask the dose also. So classically, we have to give thiamine infusion. So what is the dose? So normally in alcohol withdrawal, we should give up to 100 to 200 milligram of thiamine. 100 to 200 milligram of thiamine. But in Wernicke's, we should give more than 200 to 300. This is very important. Right? Coming to MCQ number 4. So MCQ number 4, they are asking young male with history of premature ejaculation with frequent conflicts with wife. Not pharmacological treatment of choice. So they are asking pretty much decent direct question. They are asking what is the treatment for premature ejaculation. Right? So they have given the option as cognitive behavior therapy, SCUS technique, sensate focus technique, and exposure response prevention therapy. Right? Please note, when you talk about sexual cycle, it's again an important topic where there are a lot of MCQs. We have desire, arousal, plateau, orgasm, and resolution. Right? So the disorders in orgasm is premature ejaculation. Okay, premature ejaculation. Disorders in orgasm, premature ejaculation. So if you ask me, premature ejaculation, what is the definition? So ejaculation, this is also an again question less than 1 minute, right? So I have written here the treatment of premature ejaculation is SCUS therapy, non-pharmacological therapy. Yes, you all know that the common side effect of SSRI or the long-term side effect of SSRI is delayed ejaculation. So, for premature ejaculation, SSRIs has been one of the pharmacological treatment of choice. Right? One of the pharmacological treatment of choice. So, here the side effect of one drug, that is SSRI, has been used in another situation as a treatment. Right? So, here it's very easy. The treatment of choice is SCUS therapy. Other MCQs which they have multiple times they have asked here is shortest phase is orgasm. And very importantly, please note the drug of choice for hypoactive sexual disorders is filbanserin. This also they have asked. So in coming to the disorders of desire. So in disorders of desire there are 2 to 3 disorders. One is frigidity, which is like hypoactive sexual desire in females, and other is increased sexual desire, which is known as nymphomania in females, and increased sexual desire in males, it is known as ceterasis. Most common sexual dysfunction is erectile dysfunction, and the treatment of choice is PDE5 inhibitors. For PDE5 inhibitors for erectile dysfunction, which is sildenafil and tadalafil. Okay. Sexual disorders are also an important topic, and the prototype here the answer is SCUS therapy. Right. Sensate focus technique is also used in sexual disorders, but here treatment of choice is skews technique, right? Coming to MCQ 5. So MCQ 5 was a bit tricky. Here, elderly female with staring posture, bradykinesia and having visual hallucinations, presence of Lewy body, probable diagnosis is, right? So here, the main confusion that people faced was, most probably they have faced like there has been options of visual hallucination with presence of Lewy body, right? So as you all know, this strikingly everybody told it should be Lewy body dementia, right? Lewy body dementia. What are the characteristic symptoms of Lewy body dementia? Parkinson's disease symptoms with visual hallucinations with sensitivity to antipsychotics. Sensitivity to antipsychotics. These are the classical clinching diagnostic factors in Parkinson's disease, or like what is a Lewy body dementia, right? So here, what has happened is that, like outrightly, Alzheimer's dementia is not the answer, for sure. Because in Alzheimer's dementia, Lewy body is not seen. Because Alzheimer's dementia, we have already discussed, it's basically senile plaques, right? Beta amyloid plaques. In Alzheimer's dementia, we have beta amyloid plaques. In Huntington's chorea, definitely the history of chorea should be there. The history of chorea should be there in the MCQ. Prions disease, it's not spongiform vacuolations. That is a characteristic cringing histopathological finding in prions. Like I am telling, we can rule out and find the answer. So here Parkinson's disease is the answer because staring posture with bradykinesia. Staring posture is kind of a rigidity, right? And bradykinesia with visual hallucination. Because this Lewy body dementia is has Parkinson's symptoms also. So most probably the answer here is Parkinson's disease, right? Which we have discussed: Lewy body dementia, Parkinson's symptoms plus visual hallucinations plus symptoms of dementia, right? Very important. So this dementia related topics are again very important. Coming to the last question. A patient with schizophrenia, poor response to haloperidol and thyroidazine, was started on another drug, had improvement in psychotic symptoms, but has developed sialorrhea, dyslipidemia and weight gain. The drug likely is clozapine or olanzapine. Some people had confusion here with clozapine and olanzapine, right? Let's discuss. Please note, what is TRS or treatment resistant schizophrenia? What is TRS or treatment resistant schizophrenia? If you fail two antipsychotics, poor response. Okay, this is the definition of treatment resistant schizophrenia. So if you see haloperidol and thyroidazine, two antipsychotics, so two antipsychotic have been failed in the treatment. So here the examiner is talking about treatment resistant schizophrenia. What is the treatment of choice of treatment resistant schizophrenia? Outrightly it is clozapine. Right? So clozapine is always an important drug because it causes multiple side effects. So what are the side effects of clozapine? Please note, the most important side effect is agranulocytosis, sedation, sialorrhea, and metabolic syndrome. Other rare side effects are myocarditis. Okay, so agranulocytosis is always an important topic because again I'll tell you they have asked names. What is the cutoff to stop clozapine? Okay, what is the cutoff to stop clozapine? Please note, when the WBC count is less than 3000 or the ANC is less than 1500, you should stop clozapine, right? So metabolic syndrome, again we have diabetes mellitus, weight gain, right? Now let's go back to the question. It's TRS, right? Treatment-resistant schizophrenia. Has developed sialorrhea. When they started a new drug, improvement in psychotic symptoms but has developed sialorrhea, dyslipidemia, weight gain. The drug likely is clozapine. Please note, for metabolic syndrome, the classical culprit drugs are clozapine more than olanzapine. Clozapine more than olanzapine. What is the other classical MCQ that everybody asks in clozapine is that two drugs which has been found to reduce suicidality. Suicidality is, one is lithium and second one is clozapine. Second one is clozapine, right? So these were the 6 questions that has been asked in this recent NEET, and I hope psychiatric questions were pretty easy and straightforward. They have been asked from the previous repeat topic itself. So the questions were new, but the topics always remained the same. So best wishes. So let's hope, or let's wait for the results ahead. Best wishes. Thank you, friends.
Docemy.